Okay, fine. Anyone else? First class of a surgery, cardiovascular. So everyone attended, right? Fine. So what we discussed that day? Pacemaker, and defibrillator. Just quickly, we have seen that heart shape is not this. Heart shape is this one. Where is that? This is our heart, right? We have. Ajay, did you watch video? I told you, just go with that animated video how heart pumps blood, the blood circulation. Okay, please do this. Although if you are from the core medical background, just do it. Okay, you will see how easy. If you are from the literally core medical nurses, doctors, anyone, if you see video, you will find out how easy they are explaining it. Okay, because I remember in my school, college days, no one explained me this cardiovascular system, how it goes. Okay, but if I watch video, definitely it's so easy now. That time there is no YouTube also. I'm that much old.
Email also was not there.
Huh?
Email also was not there.
No, I remember the first time YouTube, I used it for my project. That was just cafes, 2009. It was my third year. I was working on my project. I sat for 3 hours continuously in front of the screen, to just in a internet cafe. And when I came on and putting earphone with from my mobile. I had that Sony Ericsson. That is a touch mobile that era. Okay. I was listening 3 hours music, working on that. When I came out, it was little dark. And I could not realize how much time I spent there. Now it's normal for everyone. At time it's little not common. So there I have seen in YouTube how easy they teach us. Okay, everything. With all the projects and all, I was doing that. And the medicinal chemistry was my project in that subject. So similar way, you can see anything if you related with the surgery or anything, you can see animated video. It's very, very easy for you, especially for the complicated organ system such like a cardiovascular. Because if I say, just imagine on a sinus node, there is a starting impulses and all, you just imagine, but you will watch it, well and good, right? So we discussed about the blood flow anatomy and all, pacemaker, defibrillator. In the pacemaker defibrillator, we have two parts. One is a battery and the second one is a lead. Electrode or lead, right? We can insert lead, we can insert battery, we can remove lead, we can remove battery, we can replace battery, we can replace lead, we can insert complete system, we can remove complete system. That is the only thing which you have to remember for the pacemaker and defibrillator. Then later on, whether it's a temporary, transvenous, single, multiple, that we can check. Okay. If you are getting a question for the pacemaker, first thing realize what they are doing. Insertion, removal, repair, replacement. First thing that. Second, with what they are doing. What they did and with what thing. Whether it's a lead only or it's the battery only or it's a complete system. Then type, whether it's a transvenous, epicardial, temporary, single chamber, dual chamber, multiple chamber. So these 3-4 filters, if you clarify now, you will get your answer very easily with the help of the table. Okay. Any doubt on this? All good? Good. Then second part we have discussed about the CABG surgery. Coronary artery bypass graft. In that we got to know that we can create graft using artery also, using vein also, right? If we are using vein to create arterial graft, do not get confused if I am taking if I'm saying venous graft with arterial. CABG stands for coronary artery bypass graft. If I want to bypass Bangalore city, if I'm traveling from the Chennai to Hyderabad, I have to bypass Bangalore city. I don't want to get into the city. Okay, I want to bypass. There are many bypass roads, nice roads and all, right? I want to bypass one city. So it's up to me how I want to bypass. Will I take a nice road, highway, or I can go with any other outer reason? Right. Similar way, if I want to bypass coronary artery because coronary arteries are blocked, then what I'm using? Am I using artery or vein to create bypass? So don't get confused with the CABG. Or you said artery graft, then you were saying vein graft. I'm confused. CABG is a why are bypassing artery using vein or arterial graft. Simple meaning what we are taking out from the body. That is your graft type. Venous graft means we have taken vein. We have harvested vein from the any of the body location from the same patient. Okay. Arterial graft, it means we harvested artery from the any of the body part. Basically, the body part will be upper extremity and lower extremity. Okay. Now, what we have a guideline here that for venous graft, saphenous vein will be included. We are not going to code saphenous vein harvesting. It will be included. Correct? Rest all other vein harvesting we have to code it. For arterial graft, when I want to take artery, everything is included except artery harvesting is included except
The venous which you have.
not venous, artery grafting I'm asking. In artery graft, all the artery harvesting is included except radial artery, correct? Okay? In venous, only one is included, rest all we have to code. In artery, everything is included except one. I shared this slide to you, right? You did not read this. Read it, okay? It's on your group. And combination, because see, we have only 6-7 topics in a cardiovascular surgery, and you will get question may come from this part also. Now, combination graft, what we have to do? Combination graft, we have an add-on combo code, right? That deals with the only venous grafting. If I want to code first 33517 to 523, they are talking about how many numbers of veins we have. For artery, we have to code parent code, arterial code. Take 2 minutes. Let me know if you have any confusion on the last week discussed things, topic. I'll be back in 2 minutes. Okay, just hang out. Oh, बबली का नाम कर ठीक done any doubt all good Today we will then. Today what will we start first? Appendix L. Okay. I hope no one is missing today's class. Today is very important class then. Let's start with this table. Okay. Central venous access procedure. Central venous, it means the blood vessels from our central body part. Access, we are reaching to that. Access, right? Procedure, by the procedure. It means these are the procedure where we will reach out our central blood vessel, including heart, for drug delivery. I will not give a small injection for the drugs. I want to pour the drug into the heart so that it will circulate everywhere. Okay? Technique. In that we have a two things, central and peripheral. Central means exact center, central, peripheral means other part. Okay, again that if you remember, I told you about the axial and appendicular skeleton in radiology. Just stand in front of a bamboo stick, whatever bones are touching, that stick is your axial bone. Rest all are appendicular. Okay. So here the central venous access procedure divided into two sections. One is central, second one is peripheral. Now my question, while we first time I am listening this one, my question will be, how do I know that this is central, this is peripheral? Right? If they are giving, it's well and good. If they're not giving, then so we have a problem. But no problem, because everything will be given in your book. Come to the procedure. Code 363. First come to the central venous access procedure paragraph. And this is, guys, this is very important for the ED coding. If you are interested to go to the emergency department coding, which is very code. So central venous access procedure paragraph, if you see, it says to qualify the central venous access catheter or device, the tip of the catheter or device must terminate into the subclavian artery. This is subclavian artery on V. Okay, you didn't get it? You got it, right? अच्छा ये है 303 and 309. Okay. Terminate into the subclavian, brachiocephalic, iliac veins or iliac veins. Okay. The superior or inferior vena cava or the right atrium. So they have given you the name where they can insert. It may be subclavian vein, okay, brachiocephalic, innominate, iliac, superior or inferior vena cava or right atrium. If you want to know where that the name is, okay, where is that brachiocephalic, where is the iliac, you can refer the first diagrams which is there in your cardiovascular book. The venous access device may be either centrally inserted. Now highlight, what do you mean by centrally inserted? Right. So for central, they may give you direct word centrally inserted, or they will give you the access point, which is jugular, subclavian, femoral or inferior vena cava. Jugular, it is on your neck region. Subclavian, the neck and shoulder joint, means just a shoulder part. That is also coming under central only. What else? Femoral and inferior vena cava. Inferior vena cava, you remember? Blood will come from the down part to the right atrium. It is just on the chest. Femur means femur thigh area, but this is actually not thigh. Femoral vein, if they are saying, this is about the inguinal area where the thigh joint to the hip part. Okay, inner thigh. That is a femur. So this is also coming under central venous access procedure. Peripheral, basic, cephalic, and saphenous vein. Basic, cephalic, and saphenous. This three is a part of a peripheral. Okay, the cardiovascular chapter is done. Once you will first half an hour you will feel very heavy. What is this? The second half an hour you will get tricks like a pacemaker. First half an hour, what is a pacemaker? Then when I told you the table, it's very easy now. Here also same. Now you are studying as central, peripheral, basic, cephalic, so many things. You will see question, you will get to know that this is central only. Okay, how? Because central is divided into two parts again, tunneled and non-tunneled. Tunnel, if you travel in a train, you must be enjoying the tunnel part, right? Similarly, tunnel. Tunnel means there will be two entry side. You can see this diagram. One entry side of that needle is a chest, but they did not enter on the blood vessel. From the chest till the neck region, the pipe or catheter is traveling into the skin zone only, skin level only. Okay, you can see here. First entry side is on the skin. Second entry side is on the blood vessel. So from the blood vessel to the skin means from the neck to the chest, it is a tunnel. So this is coming under tunneled one. Tunnel will always be central because in central only we have a bifurcation. Central only is divided into tunnel and non-tunnel. Right? Tunnel, non-tunnel is not a part of a peripheral, first of all. Clear? This is tunnel or non-tunnel? Yeah. Asking. No. This is the needle part. This, which is non-tunnel. This is non-tunnel. We have inserted the needle or catheter directly on the blood vessel. Right? Directly on the blood vessel. So there is no tunnel part. Tunnel part will always be starting from the chest region. Okay? You will see that word tunnel, or they will give you site. That needle has been inserted on the chest first, and then it will be inserted to subclavian vein. Obviously, you know the subclavian vein is on the shoulder part or jugular vein, right? Now what they have done on the chest? It means they have created a tunnel. If it is non-tunnel, it is very easy because we have only two ports for non-tunnel. If it is tunnel, again we have a components here. Achha, why we inserted this catheter? What I told you? What is the reason to insert this catheter? To deliver drugs. Okay? To deliver basically drugs. It may be for diagnostic also sometimes, mostly for the therapeutic, for the treatment point. So, what is the thing? When they will insert that catheter into the hard part, then they will keep inserting the drugs. What they do here, they will create a port or a reservoir in our body part, where the drug will be stored, just like a battery. Okay, battery of the pacemaker. They will store the blood into our body part, or the body part resources, which is known as a port. In that port, there is a pump also, which is regulating the medicine quantity, which should release to the heart part. Okay, and that is a part of a central only. So in central we have catheter only. If they are talking only about catheter, if they are talking only about only now, if a second thing, if they are talking about catheter plus port, and now if they are talking about catheter plus pump. Okay, let me show you the code. Okay, come to the code 36557 558. 36557, which says insertion of a tunneled centrally inserted central venous catheter without subcutaneous port or pump, means only catheter, younger than 5-year age of patient. And 558 says same thing, age 5-year or older. So this is insertion of a catheter only. Now we are not talking about port or pump now. You make insert later. Okay. This is only and only for catheter. Without port and pump, tunneled, centrally inserted, and age less than 5 years and more than 5 years. Clear? Similarly, 560, 561.
This is not inserted through the chest region, sir.
Sorry, what?
This is inserted, not inserted through the chest region, right? So, though it is a tunnel.
I cannot hear you properly. Your voice is breaking too much.
So this is not inserted through the chest region, right, sir?
Okay. So that is why it is a tunnel one. If tunnel means what? They will first insert on the chest skin, and then it will go through the under the skin to the blood vessel. That is the meaning of a tunnel. So this is by default inserted in the, they created tunnel.
Okay.
Speaker is that side, right? Okay. 560, 561. Okay, that is the insertion of a catheter with port, without pump. Without pump is there or not? With subcutaneous port only, okay. So obviously only port. So what you can do, I'll share the slides and everything to you, okay? You can just make a set of these two codes, 6061, write down catheter plus port. And in the previous course, you can write down catheter only. Okay. And the last code 36563 is the insertion of catheter plus pump. There we don't have an age restriction. Only one code. Similar way you can go check with 555, 556, which is for non-tunnel. To make a set, write down non-tunnel. Come to peripheral one then. 36568, 569. Peripheral inserted central venous catheter. Short name PICC. PICC. So when I was in a AD coding, I used to get multiple times this PICC line insertion. So big name. PICC. So here we have a code based on first thing is a catheter only without guidance. And then age. Second code, catheter only with guidance. Two code, 72 and 73. The last one is the catheter plus port, 70 and 71. Just highlight, I will show you question, then only you will feel how easy it is. Anything if you'll listen first time, it sounds difficult. Now, if you wait 2-3 times, it will be very easy. Simplest question. Chalo, this one. First, decide whether it is a central or peripheral. If it is central, then tunnel or non-tunnel. If it is a tunnel, then catheter plus port, and catheter plus pump.
Six triple five is the answer, sir.
Sorry, what? Acha, answer is 36 triple five. Yes, it is a centrally inserted non-tunnel for 50-year-old. 555 or 556? 55. Yeah. What is 55 and 56 then? Younger, older, right? 556. See, these are the ports and pumps. A 63-year-old stage 4 male breast cancer patient arrived to the surgery center today for the central venous catheter placement to more effectively enable the administration of the chemotherapy treatment. The patient is draped, whatever, and plays a supine position. Anesthesia is administered using a needle. A catheter is placed into the internal jugular vein. Jugular. Check paragraph. Where is the jugular? Peripheral or central? This one, okay? Neck region. Correct, central. Now in central, what we have to see? Tunnel or non-tunnel, okay? So, acha, what do you feel here? That, okay, till now it's a non-tunnel sounds like it. The skin of the chest is incised to create a tunnel in the soft tissue. It's a tunnel because they're talking about jugular vein, which is on the neck region. But why then they're talking about chest? Because they made tunnel from the chest to the neck region, right? So that is your tunneled one. The skin of the chest is incised to create a tunnel in the soft tissue. So in the tunnel, we have again three types of code. Catheter only, catheter plus port, catheter plus pump. Let's see here. Using a guide wire, a catheter is passed through a tunnel placing the tip of the catheter into the right subclavian vein. We don't care now. What is the vein and all? We got to know central, we got to know tunnel. That's all. The end of the catheter is covered with the local soft tissue and secured with the suture. Electrocautery achieves hemostasis. The site was irrigated with antibiotics. See, there are so many information they have given. Okay. What we need, we got to know it's a central. We got to know it's a tunnel. Now in tunnel, we have a three section: catheter, catheter port, catheter pump. We need only two words, either pump or port. Did we get? No. What is that then? Only catheter. Only catheter. What is the age? 63. What is the code? How easy? Easy now? See, just remember this part. Don't remember codes and all. Okay? If it is central, two part. Tunnel, non-tunnel. Non-tunnel, well and good. Very easy. Tunnel, three part again. Catheter, catheter plus port, catheter plus pump. Peripheral, no issue. Three part. Catheter only without guidance, catheter only with guidance, catheter plus port. Now, it will be easy. Good? This is same, na? A 50-year-old gentleman with a severe respiratory failure is mechanically ventilated and is currently require multiple intravenous drip. With the patient is in his intensive care unit bed, mechanically ventilated to the Trendelenburg position. The right neck was prep and drap with the betadine in sterile fashion. The single needle stick aspiration of the right subclavian vein was accomplished without difficulty, and the guide wire was advanced into the dilator and advanced over the wire. The triple lumen catheter was cannulated over the wire, and the wire was then removed. The PVCs were encountered during the procedure. All three ports of the catheter were as per okay. First, center or peripheral, subclavian vein, central, tunnel or non-tunnel. Tunneled or non-tunneled? Non-tunneled, correct, because they are not talking about chest and all. Don't get confused with the port. No, but non-tunnel we don't have. Port we will have. We don't have a code based on the port. Good. So in non-tunnel, no problem. Only two codes we have based on the age. How difficult it is. Easy. Done. Finished. Okay. Check if you want to note. One or two codes extra we have there. So 56, 57, 57, 58. Highlight 36565, which is tunneled but two catheter via two separate venous access site. When they will insert two catheters. 365, 366, 565, 566. Both are two catheters. 565 is without port and pump. 566 with port and pump. Good. Three six five 75. This all are insertion code only we have seen, no? 36575. Repair of a tunneled or non-tunneled without subcutaneous port or pump. (576) repair of tunnel, non-tunnel. It means both are central venous access, centrally inserted. But here with port or pump. These two codes for repair. For replacement, 36578. Replacement catheter only of a central venous access device with subcutaneous port or pump, centrally or peripherally inserted. So this is for anything replacement, 578. Replacement of a catheter only. 580, 581, complete placement of a central venous access device to same venous access site. The replacement complete of non-tunnel, centrally inserted without subcutaneous port or pump. 581, tunneled without subcutaneous port and pump. 582, replacement complete, tunneled with subcutaneous port and pump. Keep highlighting, that's all. 583, replacement complete, tunneled with pump. Okay, 582 was with port, 583 is with pump. 584 is for replacement of a PICC line without port or pump. 585, replacement PICC line with port. There's one more unique code, 36592. Collection of a blood specimen using established central or peripheral catheter. So already patient have a catheter. Okay, they are taking blood sample from there. So for that code is a 36592. Okay, done. Now done.
I think this I will do in last. There's nothing to explain on this part.
Any doubt on that tunnel, this catheterization part? All good?
Sure.
Now the next thing, one person is giving heart to other. Okay, not emotionally, practically. Take heart from one person, give it to someone else, the dead body. And living person, how they will give, right? But only in a poetry we can see. I give you my heart, wala. Right? This is heart transplant. So we have here heart transplant and heart and lung transplant. Two types of transplant. In a respiratory system, you will get lung transplant only. So for transplant, we have three stages. One, taking a sample from dead body or living donor. So in this case, it's a dead body only. Cadaver donor. Okay, cadaver donor is a dead body. We will take that, will perform a surgery for that, right? Even though dead body, we will make a cut on dead body. We'll take us that heart out of from there in a good condition and store it. Right? That is the first stage. Second stage, first listen, then we'll come to the course. We'll come later on the course. Second stage is a backbench work. Before transplantation, what else we need? Okay, we need to see preparation of a cadaver donor heart and lung allograft prior to transplantation, including dissection of the allograft from the surroundings of tissue to prepare the aorta, supervena cava, intervena cava, trachea for the implantation, preparation of a cadaver donor heart, the same thing. Earlier they told about the heart and lung, second heart only. So before transplant means we take a heart and we fix it. So before fixing it, for the recipient body, on the recipient body, we have to make something, right? We will cut that aorta part, we'll separate that soft tissues, right? And then we'll take his heart out and new heart in. So just before the actual transplant, whatever work done in the recipient body, that is coming under backbench preparation or backbench work. The third is transplant. Recipient heart with or without lung allotransplantation. Allo means from different body. Auto means from same. Auto transplant means I can give my part, my organ part to me only. That is only and only case of the skin. Because skin only I can donate to myself. Right? How I'll donate my lung to my lung? Not possible practically, right? Clear? Now, see these are the tools. So for only heart, we have 33940, 944, and 945. Heart and lung, 33930, 933, 935. Cardiectomy, pneumonectomy, ectomy. The last suffix is the ectomy. It means removal. Okay? So cardiectomy means cardiac removal, heart removal. Pneumonectomy means lung removal. So cardio-pneumonectomy, heart and lung both removed. Check this codes. Just read. It will take 2 minutes. There's nothing complex. Done? What we need to remember when we are getting a question for the transplant things, need to check all three procedure has been performed today or not. Most of the time what will happen, the donor part, the first code 930940, that has already been done earlier. Now the heart is in a cold preservation. Okay, so we'll not code that part, we'll skip that part because it has already been coded earlier. Good. We'll check what they have done today. Based on today's procedure, we are going to code it. Good. 49-year-old disabled police officer with a history of smoking and heart failure and in the need of a heart and lung transplant arrives to the operation room for transplantation. The physician harvested the heart and lung graft from a donor who was a motorcycle accident and declared brain dead. Cardiectomy, pneumonectomy, and backbench work were performed on the cadaver. Then heart and lung allotransplantation was carried out on the patient. Okay, so backbench preparation, they can perform on the recipient also, and they can perform on the donor also. Like in this question they said. Okay. Where I was? Heart and lung allotransplantation was carried out on the recipient. How many things they have done here? All three or only one or two? Heart and lung removal. Okay, from here they have performed all three procedure or only one or two procedure. If it is heart and lung, you can see the blue one. So all three codes should come or only one or two? Two. Which is missing? The last line में थे ना? Second last line. Heart and lung allotransplantation was carried out on the recipient. Preservation will be included on the cadaver donor-ectomy. This including cold preservation, if required. That is also if required. Anyhow, it will require. No, they will. It's not like a dead body is also lying down in the one table. Second table we have a human being. No, they will take first that dead body's heart. They will preserve it. Remember, if you in a small cities, big cities, it happens frequently. Like I remember in my city also, we have nowadays everyone have a car. So most of the time there will be good amount of traffic. So one day the one baby need a heart. Okay, and that heart was extracted in Chhattisgarh. Okay, in the that Raipur wala part. And the heart donor was in a different state. So they have only 2 hours time to place that heart which has been obtained to that baby. So it's just a 45-minute flight journey. So they use the plane, the chartered plane, to bring that heart into the airport. And from the airport till the hospital, it should be done by 40 minutes only. And the usual traffic will take 2 hours. So what they did, that was a real incident. What did they said? Green corridor. Okay, they inform all the authorities. Authorities said, okay, we'll take care of that. So police officer, that's traffic police. They make that corridor. That once the ambulance will start from the airport, there will be no traffic in between, nothing. Just like a VIP moment. They stop everything, all the roads, everything. They block for a 40 minutes. And it was literally in 35 minutes it reached to the hospital, and the operation was successful. See, if the government people want to do something, they can do anything. See, okay. So that cold preservation is already included here. Okay, so coming back to the question: 2 codes or 3 codes? 3 codes, because they have done. They're taken out from the cadaver donor, backbench preparation also completed, and allotransplantation also completed. Right? So 3 code means B option eliminated. I am good with that. Now tell me 935 or 945. What is 35? What is 45? and 35 is a heart and lung. Here is a heart and lung, right? So A option also cancel, C option also cancel. B already we have cancelled. The answer is a D. Smart work. No need to go what is the code and all. Nothing. Your job done for the exam point of view, right? That's what you have to do in an exam. Don't overthink. If you know the concept, you know the trick, just go with that. And that's done. So within 2 minutes, you will solve this question. Good? Okay. Now the thing is, if during transplant or any other surgery, if they are taking out that heart or lung, heart and lung both from the living person, then how he will believe? How he is living now? How he is still alive? Because took heart, like a heart transplant, like a CABG surgery, okay, in a heart failure. If heart is not working, the patient is still alive, we need the equipments which works as an artificial heart and lung. That is known as the ECMOs and ECLS, extracorporeal membrane oxygenation or extracorporeal life support system. In that, we have two types of ECMOs, ECLS. Important part is this one. Veno-venous and veno-arterial. The codes are 33946. Three 47 that veno-venous and veno-arterial. Veno-venous is only about the lung support, while veno-arterial is a heart and lung both. Only heart support we don't have here. Okay, it is given in your book like this in this paragraph. Okay, veno-arterial supports both heart and lung, while veno-venous we have only lung support. So what we can do here? First we can insert. Okay, insert part leave it. 2 service and 3 procedures. Service is a initiation and daily management. Initiation means first day we have initiated. That is our initiation. Daily management is coming from the second day. Okay. Daily management will not be included on the first day. It will start from the second day. Like first day, so it's 0 days, na? 0 days operation. Then what are the procedures we can see here? We can see insertion, we can see reposition, we can see removal. Done. Codes are straightforward, simple. But the thing, what you need to do is remember these guidelines. It looks big guidelines with a much number of codes. Okay. There is one table like this. First go to the table, then I'll go with that guideline. Guidelines just look big. Okay.
It's nothing.
Okay. Initiation. Veno venous के लिए 33946. Veno arterial 33947. Daily management. Veno venous 33948. Veno arterial 33949. In a table I'm talking about. But you will see both in the both place they have given management only. Okay. So first day management will be initiation only. We don't have a management code separate. Okay. First day there is no management code. Will code only initiation code. Like if you'll buy any vehicle or something. So first servicing, first 2-3 servicings are free, right? Same thing. First day, no charges. No management charges. Management charges will be applicable from the second day onwards till the number of days where they will keep the patient into ECMOs and ECLS. Okay. Then insertion, reposition, removal codes you can see that is based on the age as well as based on the technique. Percutaneous. Per means via, cutaneous means skin. Open the body. Sternootomy or thoracotomy. Sterno is a sternal bone, chest bone, middle of your chest. Thoraco, chest area. Otomy, open, incision. Okay. Then we have based on the age, we have a different code. Okay. Now we'll come to the guideline part, and the guideline is not at all difficult. It's a common sense wala guideline. It's a very genuine or easy to follow a guideline. Okay. First thing, daily management should not be reported on the same day as initiation. Okay. That we know. For first day, no management code. It will start from the second day. Correct? Second guide, and these guidelines are there in your book, okay, in the form of this, just above to the 3946. From the ECMOs, ECLS, daily management, that part. So all the 3-4 paragraphs are guideline only. I'm just going to explain you. Let's see. Let's understand. First thing understood, daily management we are not going to report on the initiation. First day, no management. Okay. Second guideline, ECMOs, ECLS daily management and repositioning may not be reported on the same day as initiation services. Same thing. But the same or different individual. Means good doctors. So daily management we cannot report on the first day. Similar way, reposition of the cannula also cannot be reported on the first day. First day we have to code only insertion. Same thing is given in the third paragraph. Reposition cannot be reported on the insertion day. We'll code only insertion code. So you see the first day, because the first day will be the highest amount we need to spend. Doctor will get highest amount. That is why the chota mota amount is they can ignore. Reposition and management. This is very small amount. Leave it about that small amount. Okay. Fourth one, replacement of the cannula in the same vessel should only be reported using insertion. It means if they are inserting the cannula on the same blood vessel, if at one point it is not working, so they remove and they insert it on the same blood vessel. Okay, will not use replacement code. But if the cannula removed from the one vessel and the new cannula, that is not a same cannula now. New cannula we are inserting on the different blood vessel. Then we need to code removal and insertion code. 2 code for a replacement. Because for replacement we don't have a code. So what we can code? We can code decannulation and then insertion. Repositioning only we have a code. What they said about the repositioning on the third line? That the repositioning of the ECMO CCLS cannula at the same session as insertion is not separately reported. Okay, it means if they have inserted at the same time they are thinking that yeah, it is not working here, just go to the other position, reposition. That time you will not code reposition. If they have inserted already, they spend some time later after few hours or after another day, they thought, okay, we have to reposition it. That time you can code. But on the same day, you cannot code insertion and reposition. Got it? For the first day, and this all belongs to first day only. So first day you can code insertion. First day you can code initiation. First day you can code removal and insertion. Okay? Other things, no. Okay. Go and check all the codes. Let's see. Codes means what we have seen here in this one. And the good thing that whatever guideline we have seen, it's all there just below to the codes also. Like if I read 336962, they said do not report 33959 962 in conjunction with 34712, 715, 716, 812, 820 and 834. If you're done, please go with this question. Let me know what you can code. Which option you can eliminate first? A, B. Which you can eliminate. We have 340, 946, 947. A you can eliminate because A is only and only for lung. Here we have lung and heart both. Good. Now then, can we code 949 or 962 along with 47?
We cannot code, sir.
We can't. Just read down to 947. You will get it. Yeah.
Sir, option B, sir.
Option B is the correct answer. Very good. Done. ECMO, GCL is also done. All good? Okay, now we are going to discuss the most interesting part. The most interesting is not always most difficult. It's actually interesting, easy one. Okay? Before that, can you go and check these codes? 36215, 216, 217. What is that? Selective catheter placement, arterial system, each first order thoracic or brachiocephalic branch within a vascular family. How many things you did not understand here? What's the complete code? What is selective catheter placement? Catheter placement we know. Catheter is a tube-like structure which will be placed for the any diagnostic or therapeutic drug treatment. Right? That is a catheter. What is selective catheter? I don't know. Arterial system. That is artery. That is understood. What is first order? I don't know. What is vascular family? I don't know. Where you will get this information then? Okay. So welcome to the Appendix L question. Come to Appendix L. You know where is Appendix L? Appendix L. It will be on the back of your page. Check. Moving on. So 2025 book. 1011. Nine 2024, 992, 2025, 1011. So this question, if you're going to get a question from the vascular family, that you have to solve from appendix L. Do you remember this aorta? Last week I told you about this aorta part. Aorta is the largest artery. Right? Which will be divided into all other arteries. Just imagine there is a highway road, national highway, which will be divided into state highway. Then state highway will divide into the main road in the city. Main road in the city will divide into the small gully wala road, cross road, and then it will lead to your home wala road. Right? Or you can imagine a tree. Trunk of a tree is the aorta. Then branches, primary branch, secondary branch, tertiary branch, and the end branch where you can see leaves. Okay, this is how aorta looks like. So for aorta, as of now, we will discuss this. So aorta also we have a two-part, thoracic aorta, which is on the chest region. Then this arc will come on the thoracic aorta. Okay, and then it will go down to the abdominal aorta, and then abdominal aorta, lower to abdomen, it will bifurcate into the iliac arteries to go to our legs. Okay. So in abdominal aorta, there are three main branches which is derived from the aorta, which is innominate. You can see the first order, innominate. Second, left common carotid. Third, left subclavian. Can you see that one? No? Okay. What I'll do now, I have an original book picture for this segment. I will send you. Here also you can read. So I can read, you can also read that. See, this is, this is for example. Okay? Well, 2024 book is good. 25 is a little more down. Okay? So first one is a innominate. Second one, left common carotid. Third one, left subclavian. That is the first order, first branch, head of the family. That is actually head of the family. Innominates, divides into, see, like this. Now you can see innominate artery, the first one. I share not even this one. This also I can share you, but I have some pictures taken in a phone. I'll share that one also. Okay. So innominate first order, that will divide into again branch artery, which is right common carotid, right subclavian. Right common carotid is second order now, which will again divide into a third order, right internal carotid and right external carotid. Right internal carotids will again divide in a right VDA and right corticotympanic. Correct. So there are branches and branches of the arteries. At the end, what artery is in your eyes? That is also a part of the ophthalmic artery, right ophthalmic artery, which is on the beyond third order. If you can see on the last row here. What is the head of the family for ophthalmic artery? Correct. Innominate. Don't consider aorta as the head of the family. Aorta is a normal. The aorta we have always, right? The first branch of the aorta is the head of the family. Now, for that, please make a note of these 4 rules on your book. Just left side, you have much space, now you can write down this.
Right? Or you have to.
Now leave it here, right? Yeah, okay, sir, it's pretty heavy. Now you can write it. You also do the same. No. Write down, then I will explain you. Okay?
Give your bags. You have much space. Even space you have. You can use previous space.
25 pockets given good. Right side the appendix, left side blank page.
Hello?
So I hope everyone done with that guidelines. And I'm going to share this one also to you. Okay. So what first guideline says? First guideline, selective catheterization supersedes non-selective catheterization. Non-selective catheterization, we have 36200 code. So this one, okay. If in a one session, okay, now everyone focus. I'll share the slide. You can note down from there. Okay. Everyone focus on the slide here. If patient is coming for selective catheterization and they have done 2 catheterization at the same time, one on the aorta, second on the innominate. Aorta, any part of the aorta, and innominate. Should I code 36200 and 200 code and 215 both? No. My first guideline says selective catheterization. It means any blood vessel, specifically not apart from aorta, will always supersede non-selective. Non-selective is aorta. We have not selected any blood vessel, right? We are doing catheterization on the aorta only. If patient is coming only for the aorta catheterization, code it just like a separate procedure. But if they have performed any other selective part, code the selective part. That is your first guideline. You cannot code both together. Second thing, each family has to be reported separately. Achha, do one thing, first order, where is the first order we have given in the diagram now? Write down the code. 36215 is the code for that. In the first order, top to the first order, or just side to the first order, write down 36215. Here, just like this. 36215, 216, 217, 217. Done. So second question says each family has to be reported separately. So this code is not for a particular family. This is for particular order. 36215 is the same code for innominate, same code for left common carotid, same code for left subclavian carotid artery. Okay, whatever comes under first order of thoracic aorta, the same code we will code. Okay. So what if they have done two catheterization, one on the innominate, second on the left common carotid? Innominate and left common carotid. Where is the left common carotid? First order only, right? First order only. So what we can code as per the second guideline? Report each family separate. So this is two different family head, right? So you can code same code twice using 59 modifier. 36215, 36215, 59 modifier. Good. Third one, within a family, report the highest order. What if they are doing in a they have done catheterization on the first order of innominate family? The part is the innominate, and then third order, which is right internal carotid. Two places they have done catheterization on the same family. What we need to put? Highest one means the third order is the highest one here. So the only code you will code 217. That's all. No 215. The last one is the access point that I will explain you later. Okay, access point I will explain you. So this three guideline is clear. Not even the first is also okay. It's very easy one. The second and third guideline. Report each family separate, and within each family report the highest one. Highest one means it should be catheterized. It's not like always we have to report 217. They should catheterize, right? Innominate and left common carotid. Same example I have given you. Where is the left common carotid? First order only, right? First order. Both are first order. Do I need to code two code? Why? Because of the second rule. Second rule what says? Report each family separate. Correct. Right? We need to code each family separate. So 36215 and 215 with 15 and modified. Done? Very clear. Good. Innominate and write internal carotid. First order and third order in a same family, right? It is on the same family, so we are incorporating with the third order, the third rule. Within same family, report the highest one. We will report 36217 only. No need to code any other code, no need to code any modifier, nothing. Innominate and left internal carotid. Left internal carotid is what? Where is left internal carotid? Second order of the different family. So here we need to combine second guideline and third guideline both. Second guideline says code each family separate. Not even third guideline, this is only second guideline. We have to code each family separate. Within one family, code the highest one, that is the third order. This is not even a same family. This is different order. No matter, we have to code separate because of the second rule. Second rule says code each code each family separate. So left internal carotid is a second order of a left common carotid, right? Left common carotid family. And innominate is the first order of the innominate family. So you will code 36216 and 215 with 15 and modified. Remember?
Sure, doubt, sir.
Yes.
215 we can first. The innominate we can give first.
No, because 215 we have to add 15 and modify. Okay, so our coding writing suggests that if you are adding 15 and modify, let it be second one, or based code based on the severity or based on the highest level. So 216 is always the higher than 215. Code 216, then 215 is 15 and modify. Anyhow, for the CPC, we don't follow the sequencing order for the exam, but it looks good. So, that's a normal answer. It looks good for me. If you're coding 36215 with 15 modifier and 216, that also correct answer, but it will not look good. For me, that is the reason.
Okay.
Okay. Clear this one? Take time. Okay, if you want, I can share you that pictures right away. Does that picture? That only I've seen somewhere. Oh, but I not check that. So is it clear? I'm sharing in your batch, okay?
Check WhatsApp.
Now you'll see all these things. So this I have taken a picture. Now the next one, left common carotid, right external carotid and left external carotid. 4 blood vessels, 2 different family. So here you have to mix second and third guideline. Innominate and right external carotid, this belongs to same family. While left common carotid and left external carotid belongs to same family. So in each, we have to code both families separate, but in each family we have to code the highest code. Innominate and right external carotid, which is the highest one? Right external carotid, very good. So 3-6, right external carotid, 2-1-7. 3-6, 2-1-7 for third order. And left common carotid and left external carotid. That is, left external carotid is the highest one, right? 3-6, 2-1-6, second order. You can code both. Again, 15 modifier you will append with the less complicated. You should remember this one. 15 and modifier we will always keep with the less complicated. Why this orders? As orders are increasing, we can say complications are also increasing, or this is more complicated. Why so? Why innominate is the less complicated? Why right internal carotid is the more complicated? Okay. Any one of you climbed trees in a childhood, or now also if you have? Correct, no? So no one climbed trees. Okay. Yes, as you go far, the branches, it is more complicated. There is more chance that you will fall down from tree. The trunk of tree, so anyone can climb, right? But if you literally climb mango tree, then only you will realize how it is difficult. When your brother or sister, any or your friend will let down, say, oh, there I can see a good mango. Okay. Then it is difficult because you have to see and you have to climb there. With the ant also, mango ant. Okay, right internal carotid and right subclavian. Okay, so here we come, access point. Whatever the fourth guideline was, all access points are coded. So for this, just give me a minute. I will tell you how the access point works. Okay, I stop sharing my screen because I need Microsoft Word for this. Not Word, bad. And then I need a shooting tool. Because for the classroom people, I can give example. Okay. But if you're not from the Bangalore, then you will not understand that example. If I'll give you Silk Board and Koramangala all example then.
Hello, sir. Hello.
Okay, I'm going to share my screen now. Now, this is what blank sheet you shared. Okay, I'm writing on that. Okay. Just imagine now this is one road and that is a bifurcated onto two. Okay, with one finger I can draw this much only. Now I have a one catheterization here in this particular point A, and the one catheterization is point on B. Okay, how I will do that one? First I will insert my catheter from here, will go this point. I completed catheterization here. I'll come back and then I will do on the second point. Online people, please check if you can see and you understood or not. I went to the straight line and then I'll take left. I reached to the point A. I did catheterization. I came back to the junction and I went to point B. Okay. If you have realized, I have crossed this part, which is J point, junction point, twice. One, when I take left. Second, when I coming back and went to point B. Now, if I remove the catheter, I will cross that point again. Okay. So, I am excluding the removal part. So, just for the catheterization, I cross one point twice. So, for the Bangalore people, if we'll start from here, our institute, I'll go to Silk Board. Okay. Suppose I am staying in a Koramangala, I will take left from there to reach to the Koramangala. Don't tell me, we have a shortcut also. From the Silk Board, okay? From the Silk Board, we'll take a left for the Koramangala. But you will say, Vinay, can you drop me there in a Silk Board? I'll say, come. That is on my way. If I drop you there on a Silk Board, then also I can take left. So there is no complication for me. Right? I will not cross that point double. Correct. But if I say, can you drop me in Electronic City? I cannot say no. I say, okay, come. Usually the college people, they will go anywhere in the bike. To drop their friends or to pick their friends, they will go for 10 kilometers. And my friend called me me and my friend, we were on a 10-kilometer distance. 10 kilometers means in Bangalore, it's 1 hour. And he called me, I'm leaving here. I'm from my room. Come, we'll have a tea. Okay. I traveled 10 kilometers just to have tea. Right? College time. Right. So if I have to drop you in Electronic City, I will go first from Silk Board to right. And then again, I will come back to Silk Board and I will take left to the Koramangala. So I cross Silk Board twice, right? Just to drop you, because I had to drop you. Similar way, this you can see in the junction. If I am crossing twice while catheterization, removal excluded. I'm not talking about removal. You will say, how we went to the point A, then we'll pull back the catheter, then also we'll cross the J junction. That is also true. So I am just excluding the removal part. Okay. For catheterization, if you are crossing a part twice, then also now it's the same level, first level only. It's the same family. So I cannot code 2 code here, 36216 I cannot code because of the same family, right? But doctor has worked here extra. So for that I have to code 218. For the access point. Clear? This is first stage. This is first order. These are second order. Okay. So if there will be a catheterization happens on this point. Okay, this is point C. Tell me, if they will do on the C and A, will you go 2 code or 1 code? At the point of C and the point of A, will you code 918, 36918? 36218. Still you need 36218? Or 1 code is enough? Or which code is enough? Not getting answer? Okay. Consider this example as in your table. 1 first order is a innominate. 2 second order is the common carotid and right common carotid and right subclavian. Okay. So in that, if they have catheterized innominate and right common carotid, what you will code?
Right common.
Right common carotid only. Why so? Because of the
Which is the
third guideline, highest one. It means if you are telling me, or Vinay, can you please drop me in a cell code? Yes, that is on my way. I should not be coded with the 36218 again. Right? So while reaching to the point A, they can do any n number of catheterization on the between. We don't mind that one. Correct? Clear this concept? Who left, boss? Earlier we had a 10 here. All good? Okay, so where we add we use 36218, you can see here. Right internal carotid and right vertebral carotid. Right vertebral, not carotid. Right internal carotid is a third order innominate family. Right vertebral is also third order innominate family. But to reach to the vertebrae, we have to go to the innominate, take left, go to the right common carotid, again take left, reaching to the right internal carotid. Then from there we have to come to right vertebral. For that I have to cross a junction where innominate divided into 2 parts, right common carotid and right subclavian. This particular part, right? When you cross any part which is forming T shape, then you have got 368. You just imagine how you will travel to point A to point B. You will start from the innominate, then you will take left, you will go to the right common carotid, then again we will go to the right internal carotid. Then I have to come back, right? I'm coming back to the junction and then I'm taking right to the right subclavian and then I'm going to the right vertebral. Yeah. This is how we will code 36218. Not difficult. Don't make it difficult. You can discuss with your friends. They will find it more easy.
sir, when we are going the different family, then only the 59 modifier have to use, right? Huh?
Here, 59 modifier.
Yes. If it is same family, then no need to.
Here we don't need. Okay, because
Okay.
any of 218 is that is add-on code. Check 36218 is add-on code. So that is add-on code. That is the add-on code, right? That you can code along with 216, 217, 225, 226. So here we don't need 15 and modifier anyhow. When we code, when we have a complication on the billing, to make it why this is different, that is different. Just to tell insurance people that both are different, both are distinct. Don't mix it. Right? For that we need to inform insurance people so that they cannot cancel the money, the amount, the payment. Here that there is no chance that they will cancel. Anyhow, we have an add-on code. That add-on code also says code with this code. Good.
Sir?
Yes.
Right internal rotate and right vertebral both comes under third order, right, sir?
1 minute, not just a minute. I think that I cannot hear from there.
Okay, tell me again.
Yes, right internal rotate and right vertebral both comes in a third order, right, sir?
Correct. Right internal carotid and right, which one is said? Vertebral.
Yeah.
Correct. It's coming on the same third order, but you can see how they will, how doctor will perform catheterization on the dish two blood vessels. First, from innominate, the catheter will be inserted on the aorta. From aorta, they will go to the innominate. From innominate, they will take left, right, and left. Not that was right. Left, and then they will perform the catheterization on the left side. Then again, they will pull back on the halfway, and then they will insert right side. That is the reason we are adding 218 here.
Okay, sir.
So 36, 200, 215, 216, 217, 217, 218. These codes are for the thoracic aorta. Now for abdominal aorta, the code will be get changed. Instead of 215, we will have 245. 216, 246. All the concept will be same. Don't worry about the concept. Concept is same here. Just write down the codes. We have a dot line there, na? That is a diaphragm. Diaphragm is a layer which separates your thoracic cavity to the abdominal cavity. Below the lungs, above the stomach. Good. And for this abdominal aorta, the access point code will be 36248. This question, which two options you can eliminate? Just look at that. Option 217 is a thoracic aorta. 247 is the abdominal aorta. Which artery they are talking about?
Femoral.
Which artery they have done catheterization? Femoral artery. There no. Correct. Femoral artery, thigh, it will come under thoracic or abdominal? Abdominal, 217 cancel. Right? Now just check 252 and 253 whether we can multiply 253. That is the only question here now. What is it? 252, 253? Seven, 252. Yeah. Sure. Why don't have that code in my book? I don't have that code in my book even. Okay. This one here. My bad. This one 250. Okay, what is the answer? Intravascular ultrasound during diagnostic and each additional non-coronary vessels. So how many blood vessels they have done during ultrasound? Third order. So we can go 3 times, no? So C will be answer. There you can see 250, 253 can be coded. Can be coded along with the multiple parent code. Parent codes are so many there. So it's as a third order. then it will be 253 into 2. Sometimes this type of question for the appendix L will become with the radiology question also, radiology chapter. So here also 217 we have on the option A and C. It will be 247. Come please. In B and D, both options we have a 247. The only difference is 75716 and 75710, which is the one is a unilateral angiography, the second one is a bilateral angiography. So you can see the second line, dye was injected and selected right lower extremity. Angiograph was performed. So angiography has been performed only on the right side. That is why 75710 will be the answer. Okay. All good. Okay, you can complete the respiratory also today. So appendix L is very important, guys. Please check that one. Last we have here valve replacement. Okay. We have 4 types of valve. Please remember where the valve placed. Like if someone will ask you in an interview, maybe mostly, where the tricuspid valve situated, or where is the mitral valve. Okay. Then you should know where is the location. Tricuspid valve is between right atrium to right ventricle. Mitral valve is between left atrium to left ventricle. Then we have a pulmonary and aorta valve. So this is a simple one, nothing to explain. Surgical procedure on the aortic valve, mitral valve, tricuspid and pulmonary valve. What type of codes we have here? What is the code range? 33361. If you come to 33361, you will get multiple types of a code, which is divided or designed which is a TAVR procedure designed or based on the approach only. Which approach you have chosen? You selected for the particular procedure. Open femoral artery approach, open axillary artery approach, 33363, 33364, open iliac artery approach, trans-aortic approach. Right? Just approach you need to remember, that's all. In a paragraph, if you can see, first paragraph, 333, 61, 62, 63, 64, 65, 66 are used to report transcatheter aortic valve replacement TAVR or transcatheter aortic valve implantation TAVI. It requires 2 physician operators and all components of the procedures are reported using modifier 62. Now this is the time when I will explain you about the modifier 62 also. Modifier 62, can you please come and check what is the modifier, what it says in a modifier list? 2 surgeons, very good. 2 surgeons, basic example, easy example, relay race. Do you know what is relay race? School, college, no? Okay. Race, you know? You have to run, that's all. You have to run for a particular meters, right? Like if it's a 500 meter, 1000 meter, then you have to run. Relay race when two people run from the same team. but not at the same point. The starting and ending point is not same for both people. Suppose if it is a 1,000-meter race, 1 kilometer race, so one people will run from the 0 to 500 meter. The second people will be waiting for the first people on the 500-meter landmark. Okay, and they carry some sticks and all. They have to transfer. The first people has to transfer to the second people, and then in the 500 meter, first people will stop the running. From there, second people will run, and that people also run to the next 500 meter till the end point. That is relay race. You understood now? You might have seen that one. You don't know that this is a relay race. Okay. So now tell me, if a team won, who will be awarded? First people or second people? Both, obviously, because both has made effort, right? That is 62 modified. When one surgery, one CPT requires two doctors. In a radiology, we have seen one CPT requires two people, one doctor, one technician, right? We have a separate modifier there, 26 and TC. Here in a surgery, when one surgery has been performed by the two doctors, and they both doctors do not interfere each other work. They said, bhai, this is 3 hours. Not depends on the time actually. That depends on the procedure. Like valve replacement. This TAVR, TAVI. First doctor will open the heart, or they will reach till the valve. First doctor say, bhai, my job is done. I inserted the catheter till the valve. Now you do the replacement part. Okay. Second doctor will do replacement part. But we have only one CPT to reaching and replacement. Suppose that is $20,000. Very expensive. How much amount they should get? The total CPT value is $20,000. How they should get then? Each will get 20,000, or it will be split between them. Split between them half and half. How you will tell the same to insurance? Boss, please split the payment. You can't tell that, right? So what you will do for Dr. A? What is the code? 3336162. For Dr. B, 3336162. By 62 only they will get to know, acha, I have to half the payment. Because there are two doctors involved. That is a 62 modified. Understood? Payment will be half. And it should be applied with the same CPT. Okay, it's not like 361 for one, 361 for one doctor, 362 for second doctor, 9. Okay, it should be same CPT. Just remember the relay race example. Then the third paragraph, Achha, you are writing something. Third paragraph on the same, angiography, radiological supervision and interpretation preferred to guide TAVR, TAVI, guiding valve replacement, documentation, completion of the intervention, assessing the vascular access sites for the closure are included in this course. It means you cannot quote 70,000 series code here. See, code does not have any challenge things. These things in a paragraph, okay, highlight no radiological guidance code required. You can write down this. No radiological guidance code required. Third thing, next paragraph, diagnostic left heart catheterization code and the supravalvular aortography code. This all belongs from the medicine topic. Should not be used with the TAVR or TAVI. Both are same, TAVI, TAVR, both are same. So you cannot quote medicine codes also. For the down only, we have one more guideline. Diagnostic coronary angiography performed at the time of a TAVR or TAVI may be separately reportable if first they are saying don't report it. Okay. But there is a chances that we can report it separate. But there are this situation or this criteria they should meet. First, no prior catheter-based coronary angiography studies available and full diagnostic studies performed. Or a prior study is valuable, but the patient condition with respect of the clinical indication has changed since the prior study. So this you can read it. Okay. So based if this is there, then only you can append. You can quote. So I don't think so that much complicated anyone has asked till now. But remember, you cannot quote radiological guidance code here. Okay, what is pending in a heart? CMOs, CLS, CABG done. I'm just checking now if anything is pending out of. Okay, aneurysm repairs of 2-3 codes only. Embolism and thrombectomy. This is H227. Continue for 5-10 minutes or 5 minutes? It's just 5 minutes thing. Then cardio is finished. Then we have our respiratory also, the 30,000 series. Respiratory will not take much time. So embolectomy and thrombectomy, removal of a blood clot. It means, okay, these are the codes you can see. Here also, it's only thing where it is, which artery or vein we are doing the embolectomy or thrombectomy. For arterial system, 34001 embolectomy, thrombectomy with or without catheter. It does not depend on the catheter also. Carotid artery, subclavian, innominate artery by neck incision. Okay. Innominate subclavian artery by thoracic incision. Axillary brachial innominate subclavian artery by arm incision. So where they are doing, how they are doing. Done. Same thing is on the venous also, venous system. Iliac vein by abdominal incision, iliac femoropopliteal vein by leg incision, 34401, 34402. Is it? Nothing else. I'll check if there is any guideline. Yes. So, no, nothing is guideline. No guideline here. Okay, it does not take 5 minutes also. Aneurysm, you remember? Ballooning of the artery like this. How we can repair it? We can make a cut. We can tie it with the ground. Okay. This is the method how we can repair the aneurysm part. So for that, where is the code? 3380. Check 33880. What is that code? Okay, you ignore that one. 34701. Come to 34701. Endovascular repair of the abdominal aorta or the iliac arteries. Where is that R3, 4, 839? Administration. So 34701, 702, 703, 4, 5, 6 describe introduction, positioning, and deployment of an endograft for treatment of abdominal aortic pathology with or without rupture, such as aneurysm. Aneurysm, I told you, that is a ballooning of artery. They may create a graft, endograft. It means it's not like a CABG. That graft is not because to or designed to deliver blood. Okay, it's just they will make a cut and cover it, or they will, if required, they will remove that part. That ballooning artery they will remove and they will place the other artery over there. That is endovascular graft or endograft. Pseudoaneurysm dissection. These are the we have a condition: aneurysm, pseudoaneurysm dissection, penetrating ulcer or traumatic disruption of the infrarenal abdominal aorta with or without extension of the iliac artery. So 701, 702, 703. Endovascular repair of the infrarenal aorta. What is the difference? Can you find out? 701 and 702. Just find out the semicolon. Where is the semicolon? What extra they have given? Seven not one says other than rupture. 702 for ruptured temporary aortic or iliac balloon occlusion. Similar way, 703, 704 other than rupture and rupture. The locations are different on the 701 and 703. Done. Okay, this you can ignore. I'll see if there is any question on this. We'll discuss, otherwise leave it. Only with the patient within 10 to 12 minutes. Patient, this is deep. This is IPDRG guideline. Okay, leave it. See, they removed that this ballooning part, applied a synthetic graft. Chalo, cardiovascular is done. for you. Tomorrow we will go with the respiratory, which will not take much time, and question paper we can discuss. Okay? Previous question paper, whatever question paper is pending, that we can discuss. Batch 12, we have completed pathology last week, right? So you can join pathology question paper discussion at 11 o'clock, 11:30, because I will discuss with the second this new batch people. Fine, I'll complete their anesthesia chapter, and then I have to discuss this pathology question paper. So you also please join, and if you have not solved the question paper, do it today.